So 2002, overnight, 84% drop in prescriptions for hormone therapy. Women were scared out of taking something really can shift a woman's health and longevity in the future. The hot flash gets the headline, but really the real symptoms are brain fog, rage that comes out of nowhere. I had a patient come in with ringing in her ears. It can start in your late 30s. And so women, we are high functioning at all levels. We could be struggling in silence and suffering and I just gotta get through this. Okay, I'll do it. Perimenopause is a transition. This is not falling off a cliff. That's the decade of opportunity. You can't really start fixing menopause once you hit it. You need to start banking it ahead of time. I had delivered over 5,500 babies at that point. I left a thriving practice. That's where I made the transition. I said, you know what? It's not there. It's not available. You make it, you build it, you create it. They're willing to inject a peptide into themselves with no knowledge behind it. When you want to prescribe them FDA-approved hormone therapy, they're afraid of that. And that disconnect is really where accurate information and education plays a role.
Midlife isn't a diagnosis to endure. It's a window to optimize, and that no woman should have to suffer through something medicine already knows how to treat. Welcome to Stacked, the show that helps you become your own best asset. Because in case you missed it, you're allowed to have a high vibe and a high net worth. Welcome back to Stacked, the show that helps you become your own best asset. Today, we are talking about the 20 years of your life that nobody prepared you for. The reckoning that's finally rewriting the rules. My guest is a board-certified OB-GYN with more than 2 decades in the field, faculty roles across major Miami institutions, and the founder of a concierge practice and Menopause Collective built around one radical idea, that women shouldn't have to suffer through this. She's doing this work at the exact moment the science is being rewritten. The same hormone therapy that scared a generation just had its warning label removed. If you're a woman who plans to live past 50, so literally everybody listening, this is a required listening episode. Dr. Jila Senemar, are you ready to get stacked?
Oh, I'm ready.
I'm so excited about this episode. So first of all, to give you guys a little bit of background, we have never actually met, but we have a bunch of mutual friends. We both live in Miami. There's a lot of overlap. So I've definitely been Instagram stalking you for a little while. So I'm excited to finally sit down. So I want to just start with the news. In 2025, FDA moved to strip the black box warning off menopausal hormone therapy, the warning that scared a generation of women and their doctors. For the woman who's watching this and has no idea what happened, why was this a genuinely really big moment?
You know, I'm glad that we're opening with this because I think it is still newsworthy and, it should be in every headline, even though it happened late 2025. It is really coming on the heels of what happened, if we want to go back to the Women's Health Initiative study that was published back in, it was undertaken late 1990s and published and discussed early 2000. So 2002 was when the press release was held that really shifted and changed everything in terms of women's health and hormone therapy overnight. The headlines out of that study came where that hormone therapy equated to or caused breast cancer. Overnight, 84% drop in prescriptions for hormone therapy. Prescribers weren't prescribing it, patients weren't taking it. So it really shifted everything into a negative manner. So we were 2.5 decades behind where women were scared out of taking something that, we'll get into more depth about it, but really can shift a woman's health and longevity in the future. So what happened with that was they put a black box warning, the FDA. That's what they do. They give us warnings, guidelines to abide by. And the warning said that this will cause breast cancer, heart attacks, strokes, all formulations of hormone therapy, specifically estrogen. And what we know is you cannot put that kind of a blanket statement on medications like this. There are different formulations of estrogen. Even the ones that were used in the Women's Health Initiative study were the synthetic versions, not really what we're using today, which are more bioidentical, body-like. And so the risks are completely different. And so what that warning removal did. And it kind of walked back everything that was done, the harm that was done. And we realized, listen, there's newer information that shows these hormones are safe if used appropriately in the right patient population. And due to the fact that vaginal estrogen cream, which is the one that was the biggest one, it is absorbed locally and not systemically. It doesn't raise your blood levels in any significant amount, because we even have data from the Cancer Society that it can be used in breast cancer survivor patients. So with that behind us, we were able to go to the FDA collectively and make the case to remove these warnings. And what ended up happening is they not only removed it off of vaginal estrogen, but all forms of hormonal therapy, giving us clinicians the safeguards to use this in the right patient population with the right education and risk assessment. So it really gave us the okay to do what we're already doing, but now with more ease. And really the goal is to get this out to other providers.
Right.
Okay. Because as you know, not everyone is on board with this even today in 2026, despite having all of this data behind the safety of it.
I think there's so much stigmatism behind just like hormone therapy in general. So like I'm a little bit older now, but I remember being in my 20s and there was this whole big movement around, we all got put on birth control when we were like 13 years old, right? When you get your period, and kind of the rationale behind this at the time was, oh, it's going to help with your acne. It's going to make your periods lighter. I don't even know if this is true, but this is what I was told. And so many of my friends were told. So we weren't even sexually active. We just get thrown on birth control immediately. And then by the time I got to my early mid 20s, some more studies were coming out, some more books about maybe you shouldn't just blanketly be put on birth control. Why are you on it? And I remember going and asking my gyno at the time, like, why am I on this? I feel like it's maybe making me a little bit depressed, or it's just like, I wanted to understand more. And there were no resources. There wasn't really anybody talking about it. And it was very much like, I don't know. So I'm so excited that this is now a topic of conversation that people are speaking openly about on the medical side of things, across kind of all professions. So I think it's very timely. It's long overdue. But yeah, So, okay. So you built your practice around a simple, defiant idea. Women should not have to suffer through this. Why does that need to be said out loud?
I think as a society, we place taboos in place over women's health in general. Periods, we don't talk about it. Ooh, it's taboo. She's on her cycle. Like, don't say anything. When you go to the store to pick up feminine hygiene products, you kind of do it in shame, right? And I think that that has transpired to even perimenopause and menopause. And so women, as a whole, we are high functioning at all levels. You can throw anything at us and we'll do it without questioning, or really we could be struggling in silence and suffering and I just got to get through this. Okay, I'll do it. And we do, especially in our late 30s, early 40s. You have families, young kids, multiple different after school activities. You have a career that you're building. All of this is happening. Your wife, your mom, your older parents that you're taking care of. And what we do is we just go, 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 go. And the reason that we need to keep saying, hey, you don't need to suffer in silence, these are all normal things happening, is to normalize it and say, hey, there's nothing wrong with you, because that's the other part. Women do everything, and then when they're falling apart in their early 40s, like, something's wrong with me. And I want women to understand it's not just them. Everybody is going through this in their own way. No two are gonna have the same exact journey. Symptoms are completely different, and we need to normalize it in such a way where it's okay. It's just kind of like, okay, when you got your period, it was a normal part. Okay, and now I'm going through the second adolescent, if you want to call it, right? The same kind of hormonal shifts that you had in your early 10s and teens are the same that you're going to have in your 40s. And there's nothing wrong. It's just understanding it, understanding your body is going through a transition, and that there are things we can do to make it better. So I think the more we vocalize this concept, the more it's helping women kind of register it and say, okay, it wasn't just me. Everyone around me is kind of doing this, but now they're talking about it at lunches. Women, they go to lunch or this or that, or they're with their girlfriends at a soccer match, all the moms are talking. This is normalizing it, and that is where the power lies.
I mean, I started hearing about this probably about a year ago from my mom friends that were in their early 50s, late 40s, telling me, you need to start paying attention to this. You need to learn. So for those of our listeners that don't know, what is perimenopause?
Perimenopause is this decade before you actually go through menopause. Menopause is a day. It's one definition, right? It's a day where you haven't had your period for 12 consecutive months. So if you really want to look at it, perimenopause is like the transition and menopause is the milestone. Well, you hit it, okay? Perimenopause is really where we are missing pieces right now, and that to me is the more powerful part to discuss, because once you hit menopause, you kind of know. You're like, yeah, okay, no more period, I must be there. And at that point, people are like, yeah, I do have some hot flashes and this is happening. They know where to go for help or what to ask for. I think perimenopause, it's not hot flashes. You see, the hot flash gets the headline, but really the real symptoms are brain fog, not sleeping, mood disturbances, this weird rage that comes out of nowhere that you're like, wait, where did that come from? And who is that person? It's not me. And the memory loss, the lack of getting the words, weird joint aches that you never had, this tennis elbow that you're like, but I didn't have that, or frozen shoulder. I had a patient come in with ringing in her ears, dizziness, and she's like, I think something's wrong. These are really what's happening in perimenopause, and they show up first, before the hot flashes, before the cycle shifts. And it can last a good 5 to 10 years. It can start in your late 30s and go all the way through your 40s. So the sooner you kind of start listening to your body, sending you these little signals, the better you're going to fare going through the journey, and you're not going to suffer unnecessarily.
So it can start as early as kind of what age?
I would say mid-30s to late 30s. So somewhere between 35 and 39, it can start with little symptoms. Now, I think the misconception is once you have something, you need to get on hormone therapy, and that's not the conversation. The better way to look at it is, okay, your body's sending you the little signals, let me pay attention to these. Let me track my symptoms and see what's happening. Because perimenopause is a transition, therefore you can gather data and show it. It's not a lab test. It's not going to show it to you the way menopause lab tests will show it to you. Perimenopause is this fluctuating component, whereas you're trying to fix it or figure it out with one static blood draw. It doesn't work that way.
Doesn't work that way.
At all.
So there's not like a hormone test you can do to say, I'm in perimenopause.
Correct. It's more of a clinical diagnosis than a specific, okay, yes, you're there. Menopause, post-menopause, yes. We have definitive lab work that will show you, yeah, you're there. Okay, now let's fix it. But peri, no. And the reason I really hone in on peri more is because that's the decade of opportunity. That is when, if you tune in, if you learn what's going on with your body, and if you work with a doctor or provider who is knowledgeable in this space, they can guide you appropriately to really build and hone in on those lifestyle modifications that we talk about all day long, to bank what you need to bank to help you be healthier in your 50s, 60s, 70s, and beyond. You can't really start fixing menopause once you hit it, right? You need to start banking it ahead of time. And the earlier you start banking things such as eating well, your movement, building muscle, sleeping 7 to 9 quality hours a night, learning how to manage stress, and building your, social network and connections, this earlier you kind of put that all into place, the better you're going to do as you kind of traverse this perimenopausal journey into menopause.
What do you mean when you say treat or fix menopause? Is it's something you can fix?
I guess fix isn't the right word. The better word is to manage.
Okay.
Menopause is hormonal fluctuations, and when you hit that point, you don't have any more hormones left. The hormones, the way they run, these are hormones that your ovary naturally produces: estrogen, progesterone, and testosterone. And we all think it's all estrogen driven. And estrogen is the hero hormone,
Right.
if you want to call it, because it is bone protective, cardioprotective, brain cognitive protective, and cardiometabolic as well, right? So it impacts everything, but really progesterone plays a role, as well as testosterone. What we also know is in perimenopause, it's really progesterone that starts fluctuating before estrogen does. That's why your symptoms are more mood and sleep mediated, right? Those are progesterone things that are controlled. So progesterone is like considered your calming hormone. It helps with anxiety, with mood fluctuations. It helps with sleep. That's why we prescribe it typically to be taken at nighttime to help with sleep disturbances.
Oh, interesting. That's like something you would take potentially when you're in perimenopause if you're having trouble sleeping.
Exactly. And if that's like one of your biggest symptoms, and again, doesn't mean everybody should be on it for sleep only, but is it bad enough to be impacting your quality of life? That's where the question lies, is how is this impacting you? Because if it's just every other night or some nights I don't sleep well, then we do sleep training and sleep habits and certain supplementations with like glycine and things like that. Magnesium can help improve. Not everybody gets a blanket, this is what it is. But if those things don't work and it becomes more of a recurrent thing, then it's worth investigating and saying, listen, maybe this is something we want to consider. Let's give it a shot and see how you do with it. And then layer on the other hormones as she goes through and develops other symptoms. So progesterone is for mood, sleep, anxiety, and protecting the lining of the uterus, because when you're on estrogen, it can cause overgrowth of the lining of the uterus, formation of something like a polyp inside the cavity, which again, these are benign, but if left unevaluated, right, they can turn into something of a problem. So if you're going to be taking estrogen, then you'll take the progesterone to help protect the lining.
And that's kind of like, that's what you take when you're on birth control.
Similar,
it's similar,
but, yes,
but different levels.
Right. So birth control, different formulation of estrogen and progesterone, those are synthetics, and they need to be at a higher dosage in order to
prevent you from getting pregnant.
Exactly. Okay. This hormone therapy is lower concentrations of those hormones and a bioidentical formulation of it, which the body recognizes as the same as what the ovary naturally makes. That's why it really metabolizes it much gentler, and your body tolerates it much better than birth control pills. There are some people who are on birth control pills for perimenopause.
I was just going to ask that.
So they've been on it for contraceptive purposes. Now they're in the perimenopause window.
Done having kids, but they're
still on it. And guess what? But they feel well. There's no need to change at this point. You're fine. It's helping control, regulate those fluctuations. But what will end up happening is it's not going to be enough. The same birth control pill that was working when they were 42, 43, and now they're sleeping, everything's great. All of a sudden, she's like, I have this weird anxiety out of nowhere, and I don't know what's wrong with me. And what tends to happen is they're given the wrong prescription. They're maintained on their birth control pill and now given an anti-anxiety medication.
And really, they should have adjusted the hormones.
Look at them at a holistic, like take a step back and be like, where is she? Hold on, let me look at this overall. Oh, maybe she is in perimenopause, and now the birth control pill is not really doing what it needs to do, and maybe now is the time to have the conversation about transitioning from birth control pill to hormone therapy regimen.
Okay, I want to go back to sleep for a second. So I know like magnesium glycinate is very popular. Everybody, it's like the kind of gold standard for sleep right now. It used to be melatonin, then kind of the media got a hold of melatonin's actually a hormone. So at what point, if you're taking magnesium or you're taking melatonin and it's not working, how do you know when it's time to reach out to your OB-GYN?
So I think it's really based on other symptoms as well as quality of life impact. So if it's really impacting you because you know what happens if you don't get a good night's sleep. You're not sleeping, then your stress levels are up. You're not functioning at your best. I think that's when you need to really take a moment, write down everything that's happening, and schedule an appointment to go in and discuss these with your healthcare provider. Yeah, absolutely.
I feel like the biggest takeaway that I'm having right now is that you don't need to be scared of the word perimenopause. I remember hearing it from my mom friends a year ago, and like, I don't want to go to something on perimenopause. Like, that's not me. Like, I don't want to go. And also kind of being in denial a little bit that I'm no longer in my 20s, I'm in my 30s. And what I'm hearing from you is that it's not scary. It's not like this finite moment in time that means all of these other changes are going to start happening. And I think there's so much shame around aging, but it doesn't need to be.
Not whatsoever. And that's, the takeaway message should be that you should walk through this proudly and own it, because it is so much better on the other side if you really, it's mindset based. And, one of the newest studies came out of Japan. The Japanese women, really, their mindset is completely, they embrace these changes as wisdom, as I've earned my right to be here. And that's the way we should all really be approaching this. Not saying to like minimize your symptoms or anything like that, but listen, let's just change the mindset a little bit. I've earned my stripes to be here. This is what I'm here for. I have all of this wisdom behind me that I can impart on the younger population and generation, and I'm going to get better. This is not falling off a cliff. This is just a moment on the spectrum of your reproductive life. From when you get your period to when you start having babies, to when you start going through the change, to when you're post. Women spend 40% of their time post-menopause, right? 40%. We're not done. We're not going anywhere. But how do you want to live it? That's the mindset. And that's why I love embracing the perimenopausal women. I'm like, come on in, let me show you, because
it can be so much better.
Oh my goodness. And again, I think it's scary. Number one, we don't know it. Number two, it's been so taboo and shameful because women, you're only here for reproductive reasons. And if once you're done with that, you're kind of washed up and let's put you to the side. Well, we're not that generation. As you know, we're the different generation where we're building new careers, second, third careers at this junction where it's like, kind of, where were you and where am I now? Had you told me 10 years ago that this is where I would be today, I would have never believed it. But something in us is kind of coming up, this passion, and everything that I do is more of a passion project for me. People are like, how's work? I'm like, I don't know. I'm not working. I'm enjoying what I do because I see it in my patients when they come back. Like, you've given them back their life. Mm-hmm. That's something that, you can't bottle that up. It is what it is. So perimenopause, it's like, oh, let's get ready. This is the fun part. Let me show you what to do in order for it to not be such a bad thing when you hit menopause. The journey is for the younger population now, the ones who are in their 30s and 40s. For you guys, you're kind of gonna cakewalk through it a little bit easier than the ones in our 50s and 60s where we're like, okay, it was rough, but okay, we're gonna pay it back now.
Yeah. No, I love that so much. Can we talk about how pregnancy fertility ties to perimenopause? And for somebody who is maybe starting to notice some of these perimenopause signs, what would you tell them about, fertility and pregnancy? Is that something that they need to be scared about, or what does that look like?
So the ovary has always been looked upon as a reproductive organ, but it's actually part of our vital signs. It functions completely more than just giving you hormones, okay? It is a vitality sign, right? And it tells us it protects our bones, it protects our heart, it protects our brain, our metabolism, everything. And so we really need to look at it as a whole a bigger organ running everything rather than just reproductive. Women tend to be having kids later in life now. We're getting our career set up, we're doing everything else, and then we're like, oh, I'm in my late 30s, early 40s, now I want to have a kid.
I think I saw this statistic, I might get it wrong, but it was more women over 40 are having kids today than teen pregnancies.
Correct. It's shifted, okay? And the change there is, it doesn't impact your fertility if the lifestyle modifications are in place. If you're leading a healthy lifestyle, you're gonna be able to have that child. Now, the question I have to somebody who comes to me with that, scenario is, how many kids are you planning on having? Because if it's one, great, let's do it, let's go. But if it's more than that, then we really need to have a better plan, okay? Let's figure this out. With all the, things we have and all the advancements in reproductive endocrinology and oocyte preservation, now we can actually, there are tests that can be done to evaluate the age of the ovary when a woman comes to me in their 20s or 30s, and we can actually determine the lifespan of the ovary, and there are things to be done to prolong the lifespan of the ovary. So it's beautiful. I love it. I'm like, bring it. Who wants to have a baby later? And we have the conversations. What I do also, explain, and what I've noticed and seen in my own patient population is a lot of my older moms go from having a baby to postpartum straight into perimenopause. So we cannot discount the overlap there because a lot of postpartum symptoms mimic perimenopausal symptoms. So you can't just kind of dismiss them. Oh, it's just postpartum. Oh, you just had a baby. No, it could actually really be all of these hormonal fluctuations that need to be addressed completely differently.
Okay, so say somebody, egg freezing is now it's become very popular in the last 5 years. I actually did egg freezing. I was 29. It was right before the pandemic. So I was a little ahead of my time. And I remember not really wanting to share that I was doing it with anybody because people thought it was weird. My stepmom ended up having a child in her early 40s. And I was watching how difficult it was for her to go through IVF and get pregnant. And I had gone to a panel in New York City. I was in New York City living there at the time. And one of the IVF doctors, she's like, if you're in your 20s, there is no reason you should not freeze your eggs right now. It is never going to get easier for you than it is today. It is only going to get harder. So if you have the time or resources or ability to do so, it's an insurance policy. And I heard that and I saw what was happening within my own family and I decided I am doing this. Now I'm seeing so many people in their 20s, 30s making this decision. And I think it's absolutely incredible. It's so, so important. Is that the ultimate insurance policy? Or how do you know when you get into your mid 30s that you need to you want to have a child, but you actually need to go back into the doctor and kind of check in where you're at?
We used to think it was the ultimate insurance policy, but then we also realized, you can do all that oocyte preservation. And then when you go back to use them, you may not have that many that are going to turn into a viable option. And I even had patients who would go in their 20s and think, oh, this is the young patient. She's going to have thousands, we're going to get 50, 60 eggs, easy. And they'd come back with 20. And that would be like a wake up call, like, oh my goodness, I'm not as, healthy as I thought I was. Not to, and I think us with, women, we tend to then take it upon ourselves. What did I do wrong? It must be me. And that's not the case. The body is very variable, environmental factors, everything plays into this. So I think the bigger ultimate, health policy now in conjunction with oocyte preservation is lifestyle modification. And with the newer AI technology that we have, we can determine the health of that ovary at that same 29-year age, 30-year age to see, does it correlate with the oocyte preservation? So you can check an AMH and an FSH level and put it together with whatever symptoms you're having, and it will tell you, okay, this is the longevity of your ovary. And if you want to if it's It's kind of like doing biological age testing, right? You're 30, your biological age is 22. Amazing, you're doing great, keep doing it. Or you're 30 and your biological age is, 40. Okay, your cells are a lot older than where they should be chronologically. So now we have to make lifestyle changes to improve. And these are, you can improve these data points. So with the ovary, it's the same concept. Okay, I have a patient who's 30, her ovarian age is further ahead than it should be. What's going on? Then it's detailed history taking. What are you eating? Are you exercising? How's your stress level? And I know these things are not sexy, they're not the bells and the whistles and all the things that we all hear about. And we think is going to really change move the needle for us. It's really these unsexy things that if you implement them in 3 months, you will see a change in those data points. So that's where it's all at. And what that entails is a long visit. It's an somebody who actually is going to sit and listen and get all of this out of you, because a 29-year-old may not know what she's going in with and not know what the questions are to ask. So you have to really arm her with all of this information. And they come in and we explain it, and I go over everything. I'm like, now go home and think on this. Do some research on your own. We all have ChatGPT. I love it. Use it. And then bring it back to me. And then we come up with a care plan that makes sense for that individual.
Yeah. So information is power. The more you know, the more you can do with it. And just because you froze your eggs, it's not a foolproof plan. So for somebody that is, say, like a lot of my community in Brickle Babes, it's, very career-oriented, ambitious women, a lot of which are having kids a little bit later, settling down a little bit later. At what point would you want somebody to come in and just make an appointment with you?
Depending on where they are, are they married? Are they still looking for that, significant partner? Exactly. Come in and let's just see where you are, because that's really going to impact how aggressive we become with their care plan and treatment options, So if they're like, no, I'm married and everything's great, we're just not ready, then we check all of these data points and see where are they at, and then say, yeah, you're good, you have a few years, or there's nobody in the picture, then it's a different conversation.
Okay, I want to talk about your career. So you were in kind of institutional medicine for a long time, and then ultimately made the decision to go out on your own. What prompted that?
I think with us, a lot of people in my field and in my little ecosystem right now, it's personal. You go through something. I've been with my patients for over 25 years. I've been in South Florida after, training in New York. I had one job and one job only. And I built my practice with my partners, and it was a father-son team, and I was a girl. And it was back in the early 2000s where it was like, oh, let's see how this goes. And then 20 years later,
you're still there.
my whole practice is more female run than male, right? That shift happened. But I started in just general OBGYN, doing what I was taught to do. In that same time, I became one of the first robotic female surgeons in South Florida. And I saw my patients growing older with me. I saw them when they were younger, they got married, I delivered all of their kids. And now they're in this perimenopause stage, and I didn't have answers for them. At the same time, I was dealing with it myself. And I was like, wait, something's off. What's going on with me, And I remember talking to my partner, because we trained together. So him and I are like brother, sister. I'm like, I don't know what the heck's going on. He's like, I don't know either. I'm like, we weren't taught this, right? It's like, no, remember that WHI thing? And it was overnight. I was a second-year resident. And all they told us was, it's bad, don't do it, moving on. And what do I do?
And I think medicine tends, historically, it tended to be so black and white, and only in the last, 10, 15 years there's more
information, and are we questioning it more? I was trained very conventional, which is, again, I'm like a good girl, right? You do this is what you're told by your attendings, that they know better, and you don't question authority. Come to find out, all these things were set in place arbitrarily. Who knows that at 6 weeks postpartum, you're okay to go back to being normal? Who said that? We don't know. We never asked. And then I asked, I'm like, what, you're right. I definitely wasn't ready to go back at 6 weeks, but I had to, so I did. I have patients who would come to me and they're like, doc, I'm not ready. And I'm like, okay, we'll get you 2 more weeks. Okay, we will fight with your insurance and get you a few more. But where is the line? Each woman is so different. And that's what kind of sparked. I was like, wait, hold on. Why am I not asking these better questions? So it's not about this or that. It's like, wait, what's going on? And I started traveling and going to different conferences and talking to other providers. And I was like, wait, oh my gosh, what am I missing? How horrible. This is my field. I'm an OBGYN. I should be able to manage this. I can do, when they get their period, I can do the high-risk deliveries, any surgery you want, I've got it. I don't know this. How am I just going to drop them when they get to this point? That I could.
If it's not you, there's nobody left to send them to.
Right. I'm like, where am I going to refer them to? And I couldn't sleep with that. I was like, nope, that's not okay. I got to figure this out. And I started educating myself. I was like, okay, the Menopause Society, let me start there. And I went there, met everybody. I'm like, oh my God, these people are brilliant. Come to find out, they're all just like me. We just decided to take the extra step, to step out of the comfort zone and go get the education, bring it back and trial it out with my patients. It wasn't like, oh, amazing, I got it figured out. It's like, okay, let's work on this together to help improve how you're feeling. And that's where, the receipts came back. They're like, oh my God, thank you so much. I didn't know I could feel better. And for me, it was a learning curve too. I was like, these hormones are a thing that we should really be considering. And we really need to get good at it because it's not one size fits all. And that's where the rest of everything came in. I was like, oh wait, I need to check their heart biomarkers. No, I need to do this. And they're like, what are you doing? You're not a cardiologist, or why are you checking their insulin levels? And I was like, but they're all interrelated. Yeah. You can't look at them just kind of like bikini medicine, breast exam, pelvic exam, PAP, and you're done. I said, this impacts everything. And if I don't know everything else, I can't really be providing the appropriate care. I'm not saying I'm a cardiologist or an internist or an endocrinology specialist, but to a point, I can manage it to get them where they need to be. And that's kind of where everything kind of came from me, where I was like, I think I need to do this differently. And I had delivered over 5,500 babies at that point, and I was very content with where I was. People were like, don't you miss it? I do. I miss my patients, and I miss the excitement of being there for one of the most special times of their lives. But I also know they need me on the other side. Yeah. And they appreciate me being there now because there's nobody else that was there before. So that's where I made the transition. I said, you know what? It's not there. It's not available. You make it. You build it. You create it.
I've not been following my script on this because we've just been chatting, but we're hitting pretty much all of my questions I have, and I haven't been paying attention to what we're reading.
Well, the thing is, I think when you're just talking authentically, I think that's what it is. And these are just regular conversations that need to be had in every room, on every platform, to make it relatable for women, for them to understand, hey, I'm not alone. And even for me, I was like, okay, is this going to work? Like, I don't even know. I mean, I left a thriving practice, my kids are in college, they're graduating. Like I could have been like retiring, like just doing whatever I wanted to do. And it was a fork in the road. It was like, okay, do I retire and just kind of hang it up and be happy? Or do I do something different? And like, I didn't even know what it was going to look like. I literally had no idea what the path in front of me was going to look like. But one thing after another just kept happening. And I was like, well, I'm just going to go there and see what happens there. Okay, I'm going to try this and see what happens. And lo and behold, I have this practice that's now evolved into this monster that I'm trying to, manage because I see the need. Women are willing to invest in their own health. It's a membership model. I get it. I don't take insurance. But women are understanding the value of care, appropriate care. Yeah. And getting their questions answered is really where it's at. Half the time, I'm just educating. The hour and a half is spent educating and then giving them the tools and the resources to do what they need to do and then come back to me. So it's having access, having education, having availability to really guide them along this path where there was no roadmap for them before.
So how does your concierge practice work? If somebody wants to come see you, what does that look like?
It's an annual membership, and that just gets them access to me. I mean, and I don't even put a number of how many visits because I don't think that's right. Some need more visits than others. Others are like, oh, I'm great, I'll be back next year. I'm like, okay, but I'm here if you need anything else. And others, you know, if we're meeting for the first time, I think the first one is just kind of like, let's get to a lot. I'm like, I'm gonna give you a lot, and I give them handouts, and I give them a care plan, and I want them to go digest it all. Yeah. And then they come back 6 to 8 weeks, whatever they want. And okay, where are we at? What are we feeling? How do you feel about this? What do you want to try? Should we, you know, I give them nutrition plans. I give them workout regimens. I'm like, what do you want to do? And then let's see where we get to. And I'm, you know, I love data points, like, you know, body composition, all of these things. Women love it.
Blood work, trackers.
We do all of that. And when I show them their compositions, they're like, oh my gosh, I did that. I said, yes, you can still build muscle, and you will be building muscle if you know, just implement it this way. And that is really where it's about educating. So can everybody have access to me? No, it's unfortunate, right? There are, in the US right now, for every patient, for every menopause provider that society is certified, right? 36,000 patients. We're behind. Like, there's only like 6,000 of us that are certified by the society.
A huge gap.
It's a huge gap. But that's why I do all the other things that I do, right? So I focus on providing education online. Like, I do a podcast, so they get free education that way. I have my social media platform, so I do a lot of videos there, which now is being built onto my YouTube. So there's long form of it as well. I host annual events for the community to educate, so women have the tools necessary to walk into any healthcare setting and be well prepared to advocate for themselves. Because yes, this kind of membership thing is not accessible to all yet, but the education should be.
So I want to talk about how, like, what does hormone therapy look like? It could sound really scary for somebody who's like only ever taken birth control pills. Is it injections? Is it oral? Like,
we have a variety. I have like a whole basket of fun things I bring out to show patients now, because I think a visual really goes a long way for patients. So starting with the estrogen component, there are multiple different routes of delivery of estrogen, and it's estradiol, which is the bioidentical form, where the birth control pill is ethanol estradiol. So to distinguish the two, the estradiol, there's an oral form of it. So there's an estradiol pill. I like it. I don't love it, because in certain women who have a tendency for clotting disorders, it can be metabolized through the liver, and it can increase that risk. So for that reason, I kind of hold it on the back end for patients. I like transdermals. I love topicals. So the patch is one of the easiest ones and one of the most prescribed, hence why we're having this weird shortage everywhere that you hear about, which I'm like, there shouldn't really be a shortage. This is not a new thing. I think it's, there's a whole bureaucracy, I think, behind that. I don't really think it's because we're prescribing more. I think it's just women versus men medicine, I think, is what it is. So the patch is amazing, 6-7 different dosages that it comes in, and you use it twice a week. Kind of like a little Band-Aid, you put it on, nobody even knows you have it, okay? There's the estrogen gel. So the gel is used daily. There's a mist version of it as well that can be used daily on the forearm. Okay. Then we have a ring, like the birth control Nuva ring, same concept, but this is a vaginal ring with only estradiol in it. Inserted vaginally, and it stays in there for up to 3 months and gives you not only local estrogen in the vaginal tissue, but as well as systemic. So a lot of patients are like, I used a Nuva ring, I loved it, I want to try the ring. Another option. So those are the systemic versions of estrogen. We also have vaginal estrogen cream estradiol, which is the one that we use locally, and every woman, I don't care how old they are, once they're in their 40s and up, It needs to be on it. It's like a preventative life measure. Because people laugh. They're like, really? What's that going to do saving my life? Here's the way the domino works there. Vaginal tissue is dependent on estrogen to maintain elasticity, pH balance, and the protective barrier. As we get older and we lose estrogen, the tissue gets thinner. You're more prone to recurrent infections, specifically urinary tract infections. What happens when you're in your 60s and 70s? Women get recurrent UTIs that then leads to infections that are systemic, so you get sepsis, and you can actually die from that, right? All could have been prevented with a little vaginal estradiol cream in your 40s. So it's a very, kind of like intuitive way. We're like, wait, this is dummy proof. Why is not everybody talking about this? Is because you hear estradiol, estrogen, hormone therapy, and we're scared of it. But it's so safe that we use it in our post-breast cancer patients.
I feel like I am starting to hear from more and more friends in their 40s about how they're loving estrogen cream because it's making their sex life better.
There it is. That is,
we need to change the marketing handle on the estrogen cream.
We got to fix something. But here's the thing with that. That's called the genitourinary syndrome of menopause. Okay. And the way it presents in our younger patients, it could be the recurrent UTIs, or it could be intimacy is painful. And what does that do? Then they kind of shy away from it.
Or like you have vaginal dryness, which happens with perimenopause. It's normal.
Or even actually postpartum. So those 40-year-olds who are having kids later, now their estrogen levels have bottomed out and they get the same symptoms. And you can really put them on estradiol cream vaginally and hey, life is much better. So at least, lowered infections, lowered pain, and they can actually have a beautiful, amazing sex life, which they should be having. Right? That sex life is like your sexual health is a part of your health.
Yeah. It's so important.
It is not, that's the other taboo that we don't talk about, So it's critical to understand all of this and be like, it's not one size fits all. That's why, they need to pick and choose which ones they want to use for what symptoms. The progesterone is really easy. It's usually just a capsule you take at nighttime. So progesterone, it's oral micronized progesterone,
and
which
that's
is the
one that helps
bioidentical
with
the sleep and the mood. And then we got the popular testosterone that everybody equates to libido, and it's only for men, yet women make it too. So just so we all know, women make testosterone. But for women, actually, it's beyond just libido. It is really all about overall well-being because your body runs on all three hormones. It helps with muscle mass and tone, and the better part, cognition.
And it doesn't mean when we say muscle mass and tone, that doesn't mean you're going to get like big and bulky. That
Not
could be
whatsoever.
Like Pilates, hottie body.
Correct. It just kind of gives the muscle that extra oomph that it needs to maintain its shape and definition. What I love about testosterone, it comes in a variety of ways of routes to use. I tend to use a topical. I'm very, kind of conservative in what I do, but I also have patients who are on pellet therapy with me. But again, they've been with me for years. We check their levels so we're not overdosing them. And hence, they've been maintained on their dose for years. Okay? So there's a pellet. There's injectable forms of testosterone. And there's a compounded cream or the testosterone gel, which is FDA approved for use in men, but we have no female formulation yet. I'm working on that. We're taking that to the FDA next, because it's about time and we have a lot of data on it.
Great. I have a few more questions before we have to wrap. This one is such a big one. GLP-1s, obviously, we also live in Miami. Everyone's obsessed with all the peptides, GLP-1s being one of them. Is there like a correlation between that and like perimenopause or menopause onset? Are they not connected at all? What is that?
Actually, there's a huge correlation with the midlife weight gain that happens in our, patients. And it's not just a typical weight gain, it's more that body composition shift. So it's weight gain, maybe not necessarily the weight changes, but their body changes, where they're like, my clothes just don't fit the same anymore. I'm doing the same, I'm eating the same, I'm working out the same, yet my clothes are tighter, I feel fluffier. Is the word a lot of my patients use. I'm like, okay, I get it. I feel inflamed. And what that is estrogen is related. and controls insulin in the body and how the cells respond to that insulin. So there is an insulin sensitivity resistance component with estrogen fluctuations, then leads to elevated cortisol. So there's an inflammatory component, which all then leads to your body not really using the foods that you're eating, the glucose appropriately, and instead of going into the cells and being used for energy, it's being stored. But the problem with that storage of fat is it goes around your organs, not under the tissue. So that's the difference between subcutaneous fat, which is right under the skin, and visceral fat, which is right around your organs. And it's one of the most dangerous things that can lead to disease down the road. GLP-1s mediate this problem. So is it for everyone? No. In the right patient population with other medical comorbidities and things like that, it should be used, and it can be used safely. Mm-hmm. And some are on it long term because obesity is not a willpower problem. It's actually a medical condition that some people have had for a long time, just managed it better than they are now. And that's why GLP-1s are getting such a platform and such a push right now. But with that always comes the pros and the cons. So you have to make sure you're getting it appropriately with somebody who is well-versed in the treatment and usage of them. And one of the newest studies that just came out in the endocrinology world was about GLP-1 usage along with hormone therapy in perimenopausal women and the amount of weight that was lost when the two were used in conjunction together rather than alone on their own. With that said, I mean, the proof is in the pudding right there. So we know it helps, but I think it should be done on an individual basis after you've exhausted lifestyle and like you've really honed in the lifestyle. They're working out, they're eating the protein, they're getting the fiber, they're doing what they're supposed to do, yet their body is still resistant and you have those biomarkers to show it, then that's the appropriate place to use it.
I love that you're looking at health so holistically and really integrating all of these modern tools. I think, like GLP-1s come out right after the pandemic when everybody kind of gained a little bit of weight and they were FDA approved for a certain population. And then there was the big rush of people getting them from who knows where online. We also see that so much here in Miami is probably one of the most aggressive, ambitious. I don't know what the
accessible, easily to access, I think.
There's a lot of access here and people just talk about it so openly. And one of the things I find alarming with the population here is how willing people are to just inject things in themselves. They don't know where it's coming from. They don't know what the side effects are, but then they're terrified of, taking some new organic, whatever, highly credible vitamin. There's just such a big disconnect. And I wish people would look at this more holistically and not be afraid to seek out a medical professional to do this all more safely, but also just like more efficiently and healthier for you. And I love that you're looking at all of these things and there's not like a negative stigma.
And there shouldn't really be. I think the next big push is peptides, right? I literally was on the phone with a patient yesterday for 45 minutes going around in circles with her about the peptides. But all my friends are on them and And I said, and I know they're not FDA approved for a reason. They've only been studied in animal models. We have small studies in humans, but there is a list that is sitting at the FDA this month that is going to be reviewed. And if they're deemed safe enough to do more research on in human models, then we will be talking about it. But the problem we're having with the peptides right now and the peptide rush is that you can get it from any source that you want.
I was in New York a few weeks ago and you can get peptides at the bodega now.
Correct. And I've seen these bottles, there's nothing on them.
It's terrifying.
And like you said, they're willing to inject a peptide into themselves with no knowledge behind it because somebody told them and their friend looks amazing, so that's what it is. Yet when you want to prescribe them FDA-approved hormone therapy, they're afraid of that because of the risk of breast cancer. So
because of the black box
the
label.
Black box and that disconnect is really where accurate information and education plays a role.
Yeah. No, it's so important I feel very passionate about amplifying these topics just because of conversations I've had, with I have the Brickle Babes community. It's 70,000 women here in Miami, and I meet all of these women, and I love talking to them and hearing about whatever they're up to. And I just remember the first time I spoke to this girl, she was maybe 25, and she's a laundry list of all these things she's injecting and how she feels so great and this and that. My jaw was on the floor. I just couldn't even wrap my head around it. So, I think information is power, but we also I'm very happy you're here to share your story and your perspective, because it's so important to have, the knowledge. All right. So if you could give our audience one piece of physician-backed advice that she can do this week, whether she's 34, 54, to get ahead and not be blindsided, what would it be?
It would be to listen to your body and really keep track of your cycles and of your symptoms, and kind of gauge what's happening and how is it impacting you. So when you walk into the next visit, you're armed with data and information that you could use to make your case for having a bigger conversation.
So something as simple as using your notes app on your phone, or
so the Flow app that was for just period tracking, now they have a perimenopause side to them. Okay. So you can actually go on there, track your periods as well as symptoms, and you get a perimenopause symptom score. And you can print that out and take it to your provider, and then they can kind of guide you through what's going on and where to intervene, or, what can be done, lifestyle, supplements, and then medications as needed.
An Aura ring, I swear by my Aura ring. I use it as birth control, sleeps, all everything. Of the things. They just recently added a perimenopause section as well. But I love tracking my cycle, all my symptoms in there, but it's such a great resource to be able to bring to your doctor. It also tracks your heart rate variability when you're sleeping, your body temperature, so many important things. All right, now our lightning round, my favorite segment of the show. All right, we're gonna ask you a bunch of different questions. First one, perimenopause or menopause?
Yeah, perimenopause is my favorite. It's because that's where you can really make changes happen.
Lift heavy or long cardio?
Always lift heavy. Always. 2 to 3 days a week.
Protein or fasting?
Protein all the way.
What do you think about intermittent fasting?
I think it works for some people. I don't think it's a solution for every single body, because it can really put your body under more stress, which is not what you want to do. But I think overall, it's that Mediterranean diet with the high, amount of protein and the good fats is really, and not eliminating any one particular food group.
Patch or pill?
Patch. I'm a patch girl.
Supplements or prescriptions?
I think they both have a place, but if I had to go with one, I would go with prescriptions where they're necessary and used correctly.
Sleep or fix everything else?
I know. Sleep is number one, actually. If you don't fix sleep, you can't really fix anything else. So the first pillar of health is sleep.
Guys, got to work on your sleep. Blood works or symptom log?
I think it depends on where you are. If in perimenopause, it would be a symptom log. And if you're post, it could be blood work. Not to, kind of take away from the fact that you could still use blood work in perimenopause for other disease, recognition, such as iron deficiency or thyroid dysfunction. So it can be used for both.
Push the medical field or protect the patient?
At the end of the day, you still have to protect the patient, right? Because that's what we're here for. And sometimes pushing the field may not really do what you need it to do if you haven't protected the patient first.
Decline or prime?
Oh no, it's a full-on prime. We're just getting started. It's a revolution or a reinvention of yourself in a way.
No, I love it. I feel like people are looking so much better in their 40s than ever before.
Yeah, it's a new generation, I think, and they're setting. Look at Hollywood. Look at everybody and thank God for women like Halle Berry, Naomi Watts. They're all coming out. Even, Penelope Cruz just was talking about her perimenopausal symptoms. Drew Barrymore. It makes me so happy to see women that people relate to on a level, and for them to just be so open and sharing their journeys, it makes everybody else kind of feel like, aha, if it's happening to them, then I'm good. Okay, it's a normal, they're normalizing it.
So that answers my last one, I think, which was suffer in silence or say it out loud.
Oh no, the louder the better.
All right, well, this was our episode with Dr. Jila Senemar, the physician, reminding us that midlife isn't a diagnosis to endure. It's a window to optimize, and that no woman should have to suffer through something medicine already knows how to treat. If you want to know more about JilaMD and the Miami Menopause Collective, where can everybody find you?
I'm most active on social media, on my Instagram, which is Dr. Jila Senemar. And, I'm starting on YouTube and my podcast.
And where is your practice? And
it's in Coral Gables. And so the website is JilaMD.com. Easy. All the information is there, and we'd love to see you.
Amazing. We'll link everything in the show notes for you guys. Thank you so much for coming on Stacked.
Oh my goodness. Thank you for having me.
I'm excited for this episode to come out.
I'm excited for your audience to take a listen.
That's a wrap on this episode of Stacked. If this one added value, share it with someone who's ready to level up their financial life. Subscribe so you never miss an episode. And if you're feeling generous, leave a rating and review. It helps us keep the show going and reach more people who are serious about becoming their own best asset. You can subscribe to our newsletter at www.stackedassets.co for weekly intel on Bitcoin markets, business, and living well. Follow along on socials at Stacked Assets or my personal at Emily Dempsey for more on Bitcoin business and building the life you actually want. I'll see you next week. Stay stacked.